We got a lot to cover, so we'll get started. First, I want to welcome the Delta Council, Frank Howell. He's coming. Bubba Simmons, Wade Litton. And we have Paula Autry. And then our speaker from Hattiesburg, who currently lives in Nashville, Mr. Dick Cowart. And y'all got your PowerPoint?
Yeah, we just got the PowerPoint right here. Good afternoon. Chairman Creekmore, Chairman Bryan, and members of both the House and Senate Public Health Committees. My name is Wade Litton. I'm from Greenwood, and I'm part of a fourth-generation family business based in the Mississippi Delta that operates throughout North Mississippi. And I serve as chairman of the board of the Delta Council. I'm here today to introduce our team in the Delta that has been working on our healthcare crisis for the last year and a half. In late 2022, when it became obvious that our community-owned facilities across the region were struggling and in danger of closing, Delta Council realized that something must be done to learn how we can make better health outcomes in the Delta. Working together with healthcare leaders, elected officials, and the business community, Delta Council, along with others who are here today representing our efforts, began to analyze and provide direction so that we can ensure better health outcomes in the Delta in a fiscally responsible manner. The team we assembled included Baker Donaldson Health, Bose Public Affairs, KSM CPAs, and the leadership of Delta Council throughout our communities. We're extremely grateful for the support we have received from our federal and state leadership during this journey and appreciate everyone's understanding of how critical this situation is for the future of the Mississippi Delta. As I turn our presentation over to Dick Cowart with Baker Donaldson, I want to conclude by emphasizing that the Delta did not arrive here this afternoon with an ask that has been generated in the last few weeks. Instead, we have been preparing over 16 months to get to the point where we are today. And you can be assured that our team will be forthcoming and realistic about the challenges and opportunities. Thank you again for giving us this opportunity, and I'll turn it over to Dick Cowart.
Thank you, Wade. Chairman Bryan, Chairman Creekmore, members of the House and Senate, I appreciate. I spent 42 years in Mississippi and worked for Governor William Winter, and was all three of my daughters were born here, so the chance to work here again was greatly appreciated. I've been working with the Delta Council and with a distinguished group of hospital operators consultants. Paula Autry, who is a native from Louisiana and was a CEO and CFO at Henry Ford and ran other health systems in the upper Midwest. Sam Odell, who rose to be the chief operating officer of the Indiana University Health System. And what we tried to do is bring what we've learned in other rural areas and say, what have people done? And I'm going to run through a lot of information quickly because our report is not yet issued, and it's over 100 pages, and I'm going to try to give you the highlights of it. And I wanted to tell you the background and what we are recommending. Again, this is a local situation that will ultimately need to be dealt with locally, but it will need a new construct and it will need some state assistance. So first, a bit of history. The healthcare system, there are 8,000 counties in America, and in the 1950s, America decided it would be good to have hospitals. And so they developed what was called the Hill-Burton program. The Hill was Senator Lister Hill from Alabama, and gave grants to every county in America who wanted to build a hospital. Some had two, like Sunflower County, and you paid it back by providing uncompensated care. So you really paid it back by providing care. That resulted in a lot of small hospitals. Surprisingly, almost the same number as you had counties in every state, because that's why. And over time, that has evolved, where now most of the healthcare is really systems around the country. There still are a lot of small community hospitals. The Delta happens to be an area where almost all the hospitals still go back to roots in those days. They're small community hospitals they're owned by local governments. And about the last quarter of 22, as we were emerging from COVID and the disaster relief money ran out for the health systems, a whole cascading set of hospitals went really into crisis. 2 couldn't meet payroll, 3 were about to close. They were getting SOS calls in all directions. What can you do to help? And basically, I was asked to put together with a team and see what we could do. One, start to keep Greenwood open, which we have, but also to say, how do you approach this differently? How does this stop being an SOS call every time we have this? Because we've got to come up with a new model. And what have you seen in other parts of the country? Because health manpower is where it starts, the doctors and nurses provide the care, the facilities are just locations. The fragility of this in the Delta required that they employ most doctors. And because the hospital fragility, you started to lose a lot of doctors, including specialty care physicians. So there's an erosion of care that has been partially buttressed by the MHAP payments in the last few months, but it is something that's got to be approached differently, we think, if it's got sustainability. So we are going to give you our best thoughts. These are the participants. I will say Dr. Dad Edney from the Department of Health has been an active participant. Dr. Edney, thank you for being here today. All this is about getting better health outcomes. It's about health care for citizens. Everything we talk about today may be a statistic, but it's a human life. And it's an infant that died. It's a mother that died. That changed family forever. And so the need to say, can we do this differently? Can we do it better is compelling. And thank you for that. And then I mentioned Sam Odle from Bose, Paula Autry, David Blish, who's not here. In terms of the public health concerns, I can tell you there are a lot of metrics. We can all say some may be deserved, many are not. But when you study, there are places we can improve. And we have to take it seriously about what are they. And I'm going to hit a few metrics. We do more in our report. But for today, you want to know what are you recommending. So I need to save a good bit of time for that discussion. But the things that I think really just tug on your heart and create a moral imperative is that the infant mortality in the Delta is 2x between African American and white children, and it's 3x the national average. Maternal mortality in the Delta is 2x neighboring states. I mean, these are states in the Mississippi Valley Basin. The rate of diabetes in the day is 3x the national average, and the amputation rate, the Medicare amputation rate in the Delta is the highest in America. And you know what happens to a family when there's an amputation of a lower limb. 2 or 3 people can't work. It's not just the person, because now you have caregivers, and it creates a cascading set of effects. I won't spend long on the charts because probably those in the back can't read them, but I will say Dr. Edney can tell you that there is a lot of sound data that says we can do this better. And in fact, if we want to change Mississippi's health income, we must do it better. And we must do it better where our metrics are the worst, because that makes the biggest change. And I think when you look at where the infant mortality is, the cardiovascular disease, diabetes is what leads to the vascular disease and the amputation, all of those are very compelling stories, and they're analytically based. This is lower extremity amputation from a study. You can see the highest percentage in America is Western Mississippi. And that's heartbreaking. I mean, that's something you got to say, we've got to get better access to care. This is another part of that study. So with this, it starts with workforce challenges. The Delta is typically defined as 19 counties, that starts kind of, not necessarily in the lobby of the Peabody Hotel, but at least in DeSoto County, and runs south to Warren County. Its widest point is at Highway 82. And Highway 82 runs right through this area here. And so we really, since it's a bit of a teardrop, we studied the center of the Delta. Logically, the north part is still going towards Memphis and Oxford. The south part gets care towards Vicksburg and Jackson, and probably will. But in the core is where you really had the most distress. And you start by saying, what is your workforce? What do you have? What do you need? What is the age of that workforce? How long will they be there? When you look at, there are about 224 physicians in the Delta. That's at least 100 fewer that should be there. We actually do it by discipline through the area. This has got to be changed for you to have access to care. It's having access to an emergency room is not access to care. That's kind of at the end of the problem. You want to get it at the beginning of the problem. And so our ability to say, how do we change this? And particularly, how do you create a system approach that someone coming out of med school would want to be part of, that someone kind of nursing school would want to be part of? I'm going to give you a chart here in a minute about that. One of the first things we did, because it's what you should do, is go and listen. We met with the hospital boards, hospital management. We met with business leaders and physicians in the different communities, and agreed to be confidential on various things. So I'm not going to attribute to particular institutions, but I will tell you they were very participatory. They want something different. They are looking themselves to try and do it a different way. These, by the way, are just some pictures of those institutions. Some are acute care hospitals, some are critical access hospitals, some are thinking about being rural emergency hospitals. I won't get into those designations, but all of those things matter in a system of care. This is what the interviews yielded for us. One, they need to recruit and retain physicians, and they're not able to do it. Partially because of their own fragility, and partially because they don't have the critical mass at this point to be able to sustain. You don't recruit one OB or they're on call night and day. You've got to recruit 3 OBs to have obstetrical services. And you can go through various other areas like that. Next is, there's a very high percentage of the physicians who are still there who are in their 60s or 70s. And literally, we talked to hospitals where a doctor got sick for 3 or 4 days and the hospital didn't function. It couldn't function. They were down to that level of thinness of resources. Next, primary care is, for the large part, had to be employed to keep it stabilized. And using, by the way, primary care physicians are in the portal all the time using a football firm because there's not enough of them in America and they can be recruited elsewhere. And so your ability to say, how do we keep it stabilized and how be part of our system is important. The next is the specialist and surgical coverage. We'll go into that in a minute. And finally, the interesting list is they're all recruiting the same thing against each other. And the ability to be able to say, why don't you share a general surgeon instead of competing to try and get one and losing them to Georgia. All that came apart. Necessary, there's a lot of ER activity because that's the place to go. Almost no one is admitted. They are transported all around the Delta. One of the days we were at Greenwood, 3 patients were air transported out of Greenwood that day at the cost of $35,000 per patient. When you lose this infrastructure, the illness and injury does not go away. It goes somewhere else. And the cost of taking it somewhere else is also very expensive. Very high reliance on government payers. Very high penetration of Medicare Advantage plans, which is a separate subject. Staffing challenges, I think we all saw during COVID in the healthcare system that the nurse fatigue became very serious. They had to use what was called contract services. Most systems have recovered from that. A major health system in Mississippi that I'm aware of has about 10% contract nursing as kind of a norm. In the Delta, it's 50%. 50% contract nursing in many places, which costs an extra $1 million a month per hospital. So the ability to stabilize a workforce is also be able financially sustainable. A lot of deferred maintenance because they did not have, they kind of had been using it to pay salaries. And finally, health informatics and the ability to have your medical record with you, move it, find out what other people have done is an essential part of healthcare now. Virtually every system in the Delta is on an old EMR system, almost all of which are being sunsetted by their vendors, which means they won't be available in the very near future. And it's a perfect time to say, why don't we share it so that it can be something that can be done across the system and not each one buying one at a time. When we look at the essential services, I would say, and Dr. Edney was particularly good on this, is it says material. The maternal child services in the region are very, very fragile at this moment. And I will say that is extremely critical, and I would say of all the services we find, this needs immediate attention because you could find yourself without any specialty obstetric cares in a giant area, a huge area of the Delta if there's not some stability brought. In several other areas, there's some coverage, but it's aging and it's limited and it's fragile. The emergency services, I've said, are being propped up, but nearly everyone is triage and transport. And a lot of it's transport to Jackson, transport somewhere else, because there aren't the services available locally and the physicians to do it. Now, most hospitals and the medical staff have very small physicians, so they don't share physicians, smaller than 10. The hospital is almost always the primary employer of the primary care physician, and frankly, really the primary employer in the county. And so it's a very important. As Greenwood was eroding its services before our eyes in the last few months, you lost 200 or 300 jobs in LaFleur County. I mean, we know how hard it is to get 200 or 300 jobs and what we pay to recruit 200 or 300 jobs. What should we do to retain them and to maintain them? We mentioned the age of the medical staff and we mentioned the computing. On the workforce, I think I've hit many of these areas, but the contract nursing is particularly one that needs to be addressed. And I will hit later a lot of the collaborative. Nearly every region I'm working with elsewhere in the country has a grow your own workforce plan. And that is, how do you start literally in the 8th grade? How do you start with what is called pathway programs that bring children in through community colleges, through various sources into the healthcare jobs, because they're the best jobs and the highest paying jobs in many regions. But you have to organize it and facilitate it. The next, the connectivity of care. We mentioned the health information system, and out of abundance of time, I will move a bit. I will say there's some good telemedicine efforts, and I think you're aware that the University Medical Center is one of the nation's best at telemedicine, and they've done some very well-structured pilot projects there, and the ability to do those, I think, is one of the opportunities that is available. On the financial side, I'm not sure we found a positive operating margin anywhere. Now, you can have a negative operating margin, but positive cash flow, but that means you're not funding depreciation and you have deferred maintenance. And so that's been going on for a long time. And so a lot of hospitals were down to a few days, in some cases 2 payrolls, just in cash, and it turned to the counties to go to the general funds. These hospitals are bigger than the counties when it comes to their size and economic. And so the ability of the counties alone to support them is not, it may be a one-time shortfall. It's not something that is sustainable long-term. And so the ability to say, you've got to change that model. I will say the Mississippi, the MHAP program, where the payments were made earlier this month, have helped considerably. So I think the payroll crisis has subsided, but it has not really created a sustainable model yet. And the interesting thing about all the reimbursement models, and I will not get into the acronyms and other of it, but they all intersect with one another. For example, a critical access gets cost-based, but it can't have another acute care hospital or critical access within 30 miles. And so if you had two hospitals that were 30 miles apart, and one decided to be rural emergency, and one decided to be critical access, and a third decided to be acute care, and they shared the money, they would all win. But if they do it one at a time, you might have two losers and one winner. And so the ability to say, how do we manage this, maximize our reimbursement with the assets that we have, is something that has to be done looking at the entire chessboard and not just one piece at a time. Transportation, I think Dr. Edney's next area of study is to look at some of the transportation costs. They have gone up very rapidly in the Delta because of the erosion of services, and it's something that will be, all these now are private ambulance services. Many of them get county subsidies, but we're moving a lot of the patients around just trying to find them care. The new model. One is when you look at what has happened in they'll just use North Mississippi as an example. Most of North Central and Northeast Mississippi has really, have joined either the Tupelo system or the Baptist system, and all those have happened kind of one community at a time. One on various times, starting going back to the 80s, but there's two systems there. What there is not in Mississippi is the ability to have a system that is a governmental system and not a private system. That does exist in other states. There are successful examples in Tennessee and in Georgia and in Alabama. And so what we said, one of the things that should be considered here is the ability to say, if they're going to think like a region, you can't appoint them from one county, from a board of supervisors that's elected to serve one county. You're asking people to do things they were not elected to do. And so their ability to say, if we're going to change the Delta as a region, whose job is it, and how do you make it their job, and not ask people who are elected to be a county councilman or a supervisor to do it when that's not really their viewfinder. This is how it's called, public authorities. We do it with airports. We've done it with various things. For example, when we did community colleges in Mississippi, we didn't put one in every county. We have 15 regions, and they're regional community colleges. And there are various things that have been done on a cooperative regional basis, but we have not done it in healthcare. Alabama and Tennessee, I picked these and can unpack either of those examples. They were done in the 90s, and there are various examples. In Alabama, the Huntsville system, the DCH system in Tuscaloosa, the Samico system in Dothan, all those are public authorities. UAB actually has the University of South Alabama is an academic authority, so it's created for a special purpose. In Tennessee, they were called Private Hospital Act authorities. Erlanger and Chattanooga was one for many years. At one time, the Med or Region 1 was one. West Tennessee Healthcare in Jackson, Tennessee is one. These are public governmental systems. And I can tell you, because we do work with Huntsville, there's 6 hospitals, about to be a 7th, that was just announced in North Alabama that would today be closed, but for the fact that they were able to join a system, and a system in this case that was governmental and not for-profit or private nonprofit. This construct would be like this. It would sit on top of the community hospitals. They would not go away. And so there would still be a Greenville hospital, a Clarksdale hospital, a Greenwood hospital, and the ability to say, well, how do you connect them so they can work together? And it's very similar to the way the private systems work now. It's the way the Tupelo and the Baptist system both work, but they're non-governmental. And your ability to say this board, which I think should be a state and local partnership, then is in the ability to say what is our region and what is in the best interest of the region. This needs to be a local board, but it needs to look at its regional mission and not just a community mission. And by the way, any number of people, rural clinics could join it, critical access, FQHC. The second part is we believe this has a phase and should be totally voluntary. And that voluntary is every time there's a crisis, the ability to go enact something, fund it, create it, takes a year, 2 years. You know, that's not the way to deal with a crisis. So your ability to say, how do we create it, get it organized, make it available? We now can tell you there are 3 to 5 hospitals in the Delta who are seriously interested in being part of this. Until they know what it is, they're not going to commit to it. But the ability to say, let's get a regional model that starts with, we have recommended 5 that would be appointed from the state first, so the state funds it. Then as community hospitals join it, you get the Clarksdale board member, you get the Greenwood board member, you get the Greenville board member, all of them become, so that you end up with probably a board between 9 and 12, depending on how people join it. But you've got people who are not coming to represent one community, but they have a view towards the whole region. There also would be, the phrase in my parlance is tiered governance, which is probably not something you're familiar with, but that there also would be some governance at the local level, and this would provide a medical staff board that does quality of care and everything at the local level. It has covenants for essential services. Every community would decide, are we going to join or not, pursuant to a separate participation agreement. Probably look like a lease, given that the actual deed to a public hospital is owned by the county, not by the hospital itself, under Mississippi law. But that lease would have what the lease has when Oxford leased to Baptist, or when, and that is the covenants to provide services, the covenants to protect the employees, the covenants to do the things. And this provides with a basis for everyone to have both the accountability, but also the structure for a system approach. By the way, under this approach, there's no construct where we're proposing anybody loses a job. We have way too many job openings in the Delta, as I just said, for anybody to lose a job. This is a way to build jobs and to move away from contract nursing and to build it. So this is the way to say, how do we prove it and protect it and commonize it? As I said, in Mississippi, there are a number of authorities now. Some are steerage and some are operating, but interesting, we don't have any statutes on the books for health authorities. And our proposal is, let's try one. You've had the Delta leadership, the healthcare leaders say, we would like to be the beta site or the demonstration project. We would like to take a different approach, and we'd like your permission to do it. If it works, it may work somewhere else. You would decide if there would be a second one and where it would be. But under this would be our request to say, we've worked 15, 16 months on this, give us a chance. These were the investments. How am I doing time-wise? By the way, am I moving at a decent pace? I'm doing pace? Okay. I want to make sure this isn't just put everything together and presume it's going to work. This kind of build it and they will come model. We've done a lot of work trying to say, is this more sustainable than doing it individually? Because frankly, if it's not more sustainable, then you shouldn't be proposing it. And so the work is, what are the layers of sustainability? This is a Delta Rural Health Authority. That's what that acronym stands for. So if you see DRHA, that's what it is. This is kind of the organizational, which I just kind of went over. What's the leadership, participation, governance, management? The next is, there are a lot of things that can be done better. The days in accounts receivable are very high because they're running off old IT systems. And that system doesn't connect to the payer system, and they're denying the bills. And so you've got 2 and 3 times the number of days in accounts receivable that you should have, which is cash, if you can collect it, because your IT system is so old. And the ability to say, how do you get that and purchasing and managed care contracts all up to a higher level, which you could do on a common basis. How do you come in with EMR? The gold standard is Epic. That's what university has, for example, and Baptist and St. Dominic's. Is there a way to do that at a reasonable cost? Most importantly, how do you begin the provider resource recruitment to not only solidify the essential services, but add the critical specialists in the primary care? And particularly, how do you begin a systematic approach to centers of excellence? because there is not a natural hub here, like Hattiesburg in South Mississippi, this is going to be one where you're going to have a series and a flat organization. And there's going to be a natural center for maternity because the LB is going to be there. There'll be a natural center for cardiac because the cardiologists want to be there. All of that would be, but they will be shared and they will be connected to the others. Frankly, because we can do it now with technology, and in the past we couldn't, but we can now. On the financial efficiency, these are some of the recommendations, which I won't go into because I'm sure you love to talk about group purchasing and all those delightful things. This is a really key area that I mentioned, is we've got to make a serious effort to increase the physician and provider resources. And you've got to have something that's more attractive and more financially strong and sustainable to be part of it, and the collaboration to do that. This is kind of the model plan. Again, this is statistically, and we cannot possibly recruit that many doctors, but that's probably what we need. And this is where we need them by endocrinology and cardiology and general surgery, and our ability to say, where do we start and how do we do it in a logical sequence basis. The investment in maternity care is the first one because it is the most fragile now, and frankly because infant mortality and maternal mortality are tragic in the Delta now. So we would say that is job one. And the ability to say we can have anchor hospitals that have kind of maternity services that's basic, kind of uncomplicated deliveries, but you're only going to be able on this population size to really have one kind of level 2 specialty care with a NICU, and even then it's going to need to connect to Weiser and to UMC to be able to sustain, but that can work. You can have basic levels there and some level of specialty care. You're still going to have some preemies that will need to go elsewhere, but you've done what you can do for this size population. And all of this requires, coordination where the employees can move around and the doctors can also show up and have the medical record wherever the patient shows up. We've identified some others that I won't go into, but the cardiology and endoscopy and general surgery and urology are the ones that really came out as being the easiest and kind of the greatest need to be able to move, and we proposed you do one a year for 5 years and kind of layered that into a sustainability plan. The EMR can be very expensive. I think there's some people in this room who could testify to that. And so the ability to probably have an IT partner, a sub-license. For those of you who may remember when Mississippi Baptist joined the Baptist system generally, I think they saved $80 million. $80 million just on this one item by being able to share an IT system instead of having to buy a separate one. And so your ability to say, how do you do that and do it essentially, because every one of these systems is about to go. We didn't find anybody on a new IT system. And we found several where that system's not going to be serviced by the vendor in the very near future. We've also asked to look at insurance coverage. I will hit this very quickly to say that 7 of the 10 residents in the Delta have experienced affordability issues in the last survey, and that's a pretty high percentage. Affordability goes to premium costs and coverage costs and paying medical bills. I think when you look at the uninsured population, it's very high in this area. And so the upwards of 20%. This, if you're Medicare or Medicaid or CHIPS eligible, you're insured for this purpose. This is people who don't have Medicare, don't have Medicaid, don't have CHIPS, which is basically all the children, or you don't have commercial. So there's still a pretty high percentage here in this area. When you look at the poverty level by county, you can see you still have about 25% of the people below the 24% at the federal poverty level. When you look at various programs that are based at 130% of federal poverty, 138% of poverty, there are various coverage opportunities there. I know one of the new data points, I think, is that Mississippi last year had 100,000 people buy insurance on the exchange. I think they just closed this year 200,000 people. Highest increase in America. And it's because they're looking for coverage. And the ability to say, how do we provide coverage for people on very basic services? This is kind of how it breaks down when you look at 138%, which is kind of the federal kind of 138 to 140%, I think is the most the federal government will subsidize. And that's kind of how that breaks out by county. So you got 20,000 people who would fall in that category. By the way, I could spend lots of time on that, but I won't. And before we had some time for questions, I wanted to give you a few things about the tools of the future and how other people are changing things. And part of that is because this is not the only place that has got a lot of big inpatient hospitals that are empty, because it's the world is now outpatient services, and the inpatient is very highly specialized now. And so I'll tell you 3 quick stories. Worked on all 3 of them. So and one of them is across the bridge in Memphis is Crittenden County. It had a Howell Burton Hospital, opened and closed, opened and closed, opened and closed. And they finally came across the bridge and said, what would you do? What would you do? And they said, well, nobody wants to go to the old Burton Hospital. We'll build you a new hospital, but it's not going to be 120 beds built 40 years ago with ORs that don't have even fit the equipment. We'll put a micro hospital on the interstate. This was done in 2018. We'll have emergency services, outpatient, telemedicine, medical oncology. You can get cancer chemo there. You're not going to get radiation therapy there. The hospitalist model, so the hospital employs the doctors who are based there. But it said you've got to support it, and the people voted themselves. It's a county court in Arkansas, voted a sales tax to say we will support it. And it was built. It has 11 beds, 13 emergency rooms, 2 OR, 1 GI. Costs about $40 million, which for building a hospital is very cheap. To give you an example today, for Vanderbilt to build 1 bed in Nashville is $2 million for 1 bed. But what I say is it's got 150 employees, so you actually employed more people. The ED volume tripled in the first 6 months. It was new. People saw it as a different model. They saw it as a system of care, and the ability to then say, okay, people have found a place to go for care, and they're in the system, and they know where to go next. Next one is in Ventress, Tennessee. This is rural East Tennessee. It's actually 45 minutes to the nearest hospital. Population of 18,000. Hospital closed, open it. Nobody was going to reopen it. Nobody would buy it. Nobody would do it. And they said, we got to have health care. What are we going to do? They came to the University of Tennessee in Knoxville and said, we'll put an emergency room there. We had to get government approval. You can only put an emergency room within 30 miles and call it a hospital outpatient department. Well, we got permission in Washington to make it 45 miles. It was 2 to 4 hours to get an ambulance in and out of there. This was built, opened this summer. Has 6 EDs, room for 3 more, trauma imaging specialist. Costs $5.5 million. A very affordable approach to what is a small community of 18,000 people. It now is part of a system with this waiver. And frankly, there was a directed appropriations to build it. So the federal government paid that number. And they now have health care. It's new, it's part of a system, and it's got a view towards the future. It opened again about 7 months ago. And this is the last story. I could tell you 20, I prefer to tell stories actually, as you could probably tell, but I was called into Springfield, Missouri about a year ago, and they said big education community town, and the largest university in the states there, which is Missouri State, by the way, in terms of students. The largest community college in the state is there, which is Ozark Tech. By the way, that's Hal Higdon, who is the head of Ozark Tech. He has 2 degrees from the University of Southern Mississippi. And they said, if we're going to have a workforce, we're going to have to grow it our own. And so they came together and put this into a new alliance. I've actually bought them all, are putting together a program with this is the Cox Public School head. She used to be, by the way, head of the Houston Public Schools. And said, we're going to start a program to build our own workforce, and we're going to do it well in advance because we're tired of paying contract nurses and we're tired of doing that. And they came together, rolled up their sleeves and said, what do we do as a community together? Those are called pathways. If you care to know, Bloomberg Enterprises 2 weeks ago put $250 million into Pathway Enterprises for healthcare who could show they could do it. So there are people who know it work and want to fund it. So our conclusion is we've got challenging outcomes. We've got to address them, whether this way or other. Best idea wins, and this is our best idea, is to say, how do we come together in an authority model in the partnership with the state, get some seed capital, get some operating support, and let us see if we can pull it together. And I will say it's been a pleasure to work with Sam Odle and Paula Autry, and the Delta community here with Wade Letton and Frank Howell and Bubba Simmons, the past 2 presidents. I've never seen a community who hadn't said, we're willing to roll up our sleeves and own the problem, but we need help. And we would like you to be a partner. And I would also like to thank Dr. Dad Edney, who is a son of the Delta and practiced in Vicksburg for many years, has been totally supportive, knowing the essential nature of what we're doing. So thank you, Dan, for all you've done to help us. So, Mr. Chairman, that concludes my comments.
Thank you, Mr. Cowart. We'll open up the floor for questions, and I've got one. You had a 5-year plan, and that was including adding 38 doctors, not assuming nobody retires, which sounds like...
Yes, sir, there are a few retirements, but we hope we can delay them.
But that is all using current facilities. We're not adding anything new in that 5-year plan.
Yeah, this does not include new facilities. I will say that, if we could get a directed appropriation, we've got, Clarksdale really needs a new hospital. It's probably the oldest of the ones we've talked about. Queen County obviously is going to get a new hospital. So I think it's good to have this conversation because what it ought to be is planning things that are part of a system.
If nothing's done, what will be left in 5 years?
Well, I fear you'll have the largest healthcare desert in America, and you'll be staring at a situation that will take hundreds of millions of dollars to correct. And it will be tragic. It will be just heartbreaking. And we came really close to a cascading set of effects. The 2 largest hospitals in the Delta, when I got a call, were not going to meet their next payroll. It was that close. And as soon as you don't meet one payroll, what happens? They're gone. So I will say we do have a window here. Thank you for helping to do that, but we need support to rebuild this and to make it more formidable and sustainable.
And the last one for me, but when will your final report be ready?
Really, probably the next 2 weeks. So we were on timetable to get it the first week in February. Your hearing was a little before, and so we agreed to come testify with our preliminary thoughts. But I know there's probably some people in the room who represent the Delta, and we have follow-up meetings planned with everyone, but we ended up having to resequence this, and so we're going back to our stakeholders kind of in a recircle, and so we want to do that. So probably by mid-February.
I would encourage this as soon as it's ready, share that with both committees as soon as possible.
Yes, sir.
Questions? Gentleman from Washington.
Thank you. Thank you, Mr. Chairman. Can you tell me who were the stakeholders that you spoke with in Washington, Bolivar, and LaFleur County? Who were on the board of supervisors, the city councils? Who did you speak to?
Sure. Paul?
Yeah, for Greenwood LaFleur, we spoke to, in addition to the hospital leadership, we met with hospital board members, and we also met with some of the county board of supervisor members.
Okay. It has been represented to me that the board of supervisors in Washington nor LaFleur County knew anything about this. So either that somebody has been misinformed, or y'all just selected who you want to talk to. Although I agree a regional approach is a possibility, but I do think you need to have stakeholders who are in charge of placing people on those boards at the table. The second thing is, which legislature out of those counties did you have a conversation with out of those boards? Okay, so now the regional approach that Delta Health System tried, the regional approach with Clarksdale and with San Antonio was an idea, and it only failed because we did not expand Medicaid. So with the expansion of Medicaid, would this cut the cost of what you're trying to do or enhance it?
The expansion of Medicaid would be a very favorable event. We'll say we built the model for it to expand or not to expand, so it is not dependent on that, but yes, sir, it would be very favorable.
So, according to your proposal, how do we come with these regional boards? Who will place these persons on this regional board?
Well, again,
This authority.
the first thing that people want to know is kind of get a...
No. Answer the question I asked. Don't go around. Who will place those people on that board? How would they be selected? Which entity would put them on that board?
Sure, and I will say, for the authority to start, before it does anything, the proposal was the governor would appoint 3, and the legislature, presumably through the lieutenant governor, appoint 2. Then you would add from each community as they joined. And so those appointments would come from the communities as people join. If nobody joins, the authority operates nothing, because that is a totally voluntary system, and people have to believe it's a better model and they want to be part of it, and they will then join and agree on their governance when they join.
So, and this is my last question, Mr. Chairman. Don't you think it would have made sense to involve the people who have been investing in these particular entities to come to the table prior to you presenting a proposal, rather than say, hey, this is what we figured out y'all need to do and this is what y'all got to do to survive? Don't you think we should have had some round-the-table discussion with everybody who has stake in the game? I'm a 46-year member of Delta Health System. My mom worked there and several other people. I'm so intimately involved that you can find my name inside that building. And the only person that has said anything about a concern in this conversation has been the CEO that y'all came by and passively talked about what you wanted to do. I have some concerns about this. I'm not against a regional approach, but the proposal that you present and the information that I've read, I do not agree with.
Gentleman from Hines.
Thank you, Mr. Chairman. Piggybacking off my colleague, Representative Hines, I have a couple of questions. What was the conversation with the FQHCs about this program?
We interviewed them like we did the other stakeholders.
What was the outcome of that interview?
Well, I was not in that interview, but Paula was. So I'm handing it to Paula because some of these she did,
right,
and others Sam Odell did, some I did. Paula did the FQHC.
Yes. We met with Delta Regional FQHC, and just really at that point trying to obtain information and feedback to assess what the solutions are. They were very interested in collaborating with the hospitals primarily on primary care services. They're talking to Greenville now about providing primary care services, and they'd like to do that for the authority. So they were interested in hearing further.
All right, thank you. And my next question, which was mentioned, I saw you mention Missouri. Was Missouri mentioned in this?
Yeah, well, the workforce.
The workforce portion. State of Mississippi, we have transportation issues, and you outlined this in the diagram. What was the solution behind the transportation part? Because the majority of the individuals who are in the Delta, and my colleague can correct me, transportation-wise, distance from their home to a hospital, a working hospital, is what, 15, 20 miles, maybe more than that?
Well, I would say, if you allow me to use the word transportation equity, you may not agree with it, but it's a term that actually exists in the Department of Transportation. It's not a healthcare term.
Right, I understand, yeah.
But access to a motor vehicle by families is at the highest rate in the Mississippi Delta of anywhere in America. we have been to CMS and HMS and said they need to take that into consideration when they're drawing these 30-mile radiuses, because there is no bus service, there is no taxi service, they do not have access, and we have presented it, and we've gotten a lot of support. And I will say Congressman Thompson has been fully involved in all this discussion. He has helped us get the ear of the highest levels of CMS to be able to say, we've got to do this differently, help us, because we have fact situations that don't exist in other parts of the country. For example, in the Rocky Mountains, if your road is snowed in, you get a 15-mile radius. But in the Mississippi Delta, if you've got a road, but you don't have a car, it's still a 30-mile radius. Well, how's that access? I mean, that's just not. So I will say those are very good arguments, and I agree with them.
All right, thank you so much.
Gentleman from Sunflower.
Thank you, Mr. Chairman. And I just want to make a statement, if I could, very quickly. First of all, I'm very shocked that we're even here. I'm very appalled. This is my first hearing of it, and I live in Indianola. I represent, as well as my other colleagues here from the Delta. I'm just so sick and tired. This is my 6th session. I am so sick and tired of people outside of the Delta telling folks in the Delta what we need. And we're not at the table. To have these partners that you just referred to, Baker Donaldson, Department of Health, whomever Bowes is, whomever KSM, CPAs, and all of these advisors, to come and say to us, this is the problem. And we've been telling you all the problem for the last 30 years. We've been telling this state what we need. And the state has consistently robbed and taken economic opportunities from the Delta. You have starved the Delta economically. This body just made some investments in a special, extraordinary session, which is unheard of. If these same economic development opportunities were in the Delta, we wouldn't be sitting here. The gentleman from Washington mentioned Medicaid expansion. These are some conversations that our governor has refused to have. So we can tell you from the Delta what the problem is, because I guarantee you, if this was the coast, we wouldn't be sitting here. If this was Oxford and Tupelo, we would not be sitting here. If this was DeSoto County and North Mississippi, we would not be sitting here. President Ronald Reagan said the 9 most terrifying words in the English language is, I'm from the government and I'm here to help you. That's a problem here. And I think it is very disrespectful. And when we starve the region economically by not making major economic investments in that area, and then come back to say, well, I'll give you some help. I know what's wrong, but I'll show you now, I'll tell you now, this is what we're going to do for you. It's disingenuous and very disrespectful. Do we need to do something? Yes. But not to have an elected legislator at the table is very disrespectful. I think it's a problem. Because guess what? The people elected us there. And to have this, and to have a draft bill from people who don't represent that area, it's an issue that I have, and I take it personally.
In all due fairness, Mr. Cowart was hired by the Delta Council. So.
I understand.
That's part of the problem.
That's the issue. The Delta Council is my back door.
Gentleman from DeSoto.
Thank you, Mr. Chairman. I appreciate what you're trying to do here as far as getting access to care to places that are underserved. And I was curious if maybe a part of that equation that has been overlooked might be added into it, and that is we have nurse practitioners in this state that are qualified to go in and be a front line, but yet we have this collaborative practice agreement which limits them. And there are many states out there, Arkansas, I think maybe even Tennessee, where a nurse practitioner can go in and open up a family practice clinic and provide services and to operate within their scope of care, but yet we seem as a state unwilling to give them the leeway to do that, because I believe there are some entrepreneurial nurse practitioners that would move to the Delta to open up their own practice. We have over 51% of our counties, like you said, that are in a obstetrics maternal desert. And I've got to build this session that would pull nurse practitioner midwives out of that so that we could provide care to some of these counties. Do you see that as being maybe another aspect and solution to your equation that we could take and create? Because you said it your own words that we're not going to be able to recruit all the doctors. It's going to be a hard thing to do, but we have nurse practitioners around the state that would go to the Delta and provide care if that was a part of the equation, that we freed them up to do that. Do you not think that could be a part of the solution?
We absolutely agree that advanced nurse practitioners are part of the equation, and my inefficient use of physicians was not intended to refer to MDs or DOs or even to APNs. And so I will just say that the study looked at that, and there's a great opportunity to leverage the workforce with advanced nurse practitioners. I'm not familiar with the licensure issue, but I will say in rural areas across the country, yes, they are very much part of the equation.
And they in many states, they have kind of saved these areas of underserved, and if we open it up to our midwives, then this maternal desert that we have in our state that just keeps growing because we have OBs leaving the state en masse, we could get some help to these folks. And I think that needs to be a part of the equation, not just regional, whatever, but also to look at reforming how we do things in our state. And I hope you'll consider that in your proposal.
Yes, sir.
All right. Just for the sake of time, we need to move on. I know y'all have another meeting. Thank you very much. Yes, ma'am. I'm sorry. I didn't see you.
I just wanted to ask the gentleman, I don't know anything about your bill or anything like that, but you did describe an authority in 3 hospitals under that, federally qualified health centers, DMEs, hospice, home health, and all that, as a part of this regional proposal that you're making, right?
Yes, any number of hospitals and other healthcare organizations could join or not.
And so, I was in a meeting a while ago where they said legacy was old, so I'm old, but I do remember that the state of Mississippi had an eleemosynary system that was set up similar to what you're talking about, where you had hospitals in a certain region, and they actually cared for the working poor. You do remember that, right? And so, exactly. So, I guess what I'm trying to get at is that what you're trying to do is propose something like that but you have some governing authority at the top. What hospital then would be the one where once a person reaches acute trauma or that kind of thing, would the medical center then be where they would go like they did when we had the eleemosynary system in your proposal?
Yes, well, first, we're not proposing any charity hospitals. So I will just say the eleemosynary system had 3. There's one in Meridian, one in Laurel, 4. And it created a different standard of care. And there was a stigma. You weren't mainstream, just like sending your special education students. So no, that's not the approach. This is hospitals who treat everybody at the same place.
Public option, what you're proposing?
Well, but it's a public hospital now, but it's a county hospital.
A public option.
Well, it's a public option to bind them together.
Okay, and so when we had the eleemosynary system, which was a board, I'm talking about the board itself, and then the hospitals under there was a public option, correct? So this is a similar kind of...
I frankly don't recall if they use that terminology, to be honest with you, but the charity hospital system has been dismantled all over America, and I just say, this is not to recreate any charity hospital. This is a way for full-service hospitals that treat a full ambit to work together more effectively. That's what we're intending to do.
Okay. I guess maybe I shouldn't use the word eleemosynary, because that seems to have taken you somewhere else. I'm still trying to figure out that what you're proposing is that you will have regional hospitals with some governing authority above it, right? And then these particular hospitals will do certain things so that you won't have redundancy and this kind of, well, you probably have this redundancy, but you wouldn't. So I have two questions. When a person gets to an acute situation that's outside what these hospitals
Right.
can work on, where does that individual go? Do they come down here to this medical center? Do they go to Memphis? I mean, where do they go?
Yeah, if they need a high,
Your proposal.
well, under our proposal, if they need a higher level of care, they would go, and we would, because you have a system approach, you would try to facilitate that more efficiently than just call an ambulance. And, you would be able to say, we're sending you a patient, we've triaged them, we've taken some labs and tests, we're sending them, whether it's to UMC or wherever it may go, to different places, to say, we're transporting that with their consent, they've got to accept it. But we're bringing that with the information for you to pick up care, because you're not going to have quaternary care in the Delta. There's not enough people. You're not going to have a children's hospital in the Delta.
That is the part of-
Yes, yes,
The medical center would then be a part of this proposal, right?
yes.
Okay, then on the grow your own, because that's an interesting concept. The gentleman talked about this major investment that we made the other day, and that project Atlas talked about $4 million in STEM, $10 million to the universities, $16 million in what they call an advanced kind of training. You said that you look forward to us starting in the 8th grade with some sort of science or health-related education to get children in that pathway. In your proposal, is that part of what we're expecting from the state to fund as well?
No, ma'am. I think it's examples of if you built a collaborative environment, and when you look at where that's been done in other parts, these pathway programs usually begin in middle school. I gave you an example of one that had targeted the 8th grade.
How does it pay?
Well, they usually have to decide that. They usually are, it's not, so I will say there's no state money in the one in Springfield, Missouri right now.
This proposal that you're going to bring back to the chairman, you're going to have all that out there, right?
Yes, ma'am.
Okay, thank you.
Thank you, Lady from Jones. All right, we're going to move on in fairness for UMMC. We have Dr. Alan Jones and Dr. Lou Ann Woodward and Anna Moak Sparks here somewhere, I believe. We're turning it over to you, Dr. Woodward.
All right, I trust somebody is going to switch out the slides for me. Thank you. Yes, I'm Lou Ann Woodward here. I've got Anna Moak Sparks and Christy Sims with me today, if they would just wave quickly, and Dr. Alan Jones. I am the Vice Chancellor at the Medical Center. Dr. Jones is the Associate Vice Chancellor and works with all the clinical part of the enterprise. I'm going to just pause a second and let the pieces get passed out and let the room shift a little bit. That's all right. All right, what do I, no, hang on. Let's see what I point at to move this. Where do I point the clicker to make it move? Right here? Mm-mm. Thank you. Thank you. All right, I'm going to go ahead and get started because I know everybody is interested in the time of day, so thank y'all. As I said, I'm Lou Ann Woodward. I grew up in Carroll County, so I grew up in one of those counties that was featured in the last presentation. My father still lives there. I have family that lives there. During all of my life growing up there, we had either one or no physicians in that county. So from the standpoint of personal experiences as well as our professional work, I want to tell you that Dr. Jones and myself and all of us at the medical center spend a lot of time and energy thinking about access, doing projects to increase access and to look at healthcare outcomes, including the Mississippi Delta. I agree with some of the comments from before that something different needs to be done. I think we know that what we've been doing all this time hasn't really worked, and something different needs to be done. So I'm going to talk a little bit about access in just a minute, but just for those of you that may be new or maybe don't know, let me tell you a few things about the medical center. We have a unique role in the state of Mississippi in that we are the only academic medical center. That means we do education, research, and provide clinical care all at once, all the same time, every day. We have the only children's hospital, the only level 1 trauma center, the only level 4 NICU, the only place doing organ transplants, and you can see here the list of the organs that we transplant: bone marrow, liver, pancreas, kidney, heart, and lots of subspecialists that are found nowhere else across the state. We are very, very often the receiver of that SOS call that you heard Mr. Cowart talk about because of these things that we do. We have a little over 10,000 employees. We are the second largest employer in the state, the largest being Ingalls on the coast. And sometimes I like to say we're the largest employer of Mississippians because some of their employees are not Mississippi residents. More than 3,000 students, residents, and fellows. That's larger than some of the colleges and universities around the state. On an annual basis, we bring in close to $100 million in extramural funding for our research. These are federal grants and other types of dollars that are new money to Mississippi. So all of this is a true economic engine for Jackson and for the state of Mississippi. We are also a safety net hospital, the SOS call. We are a safety net hospital and take care of a lot of patients that are uninsured, underinsured, the very, very sick patients. We're the only hospital in the state with a statutory mandate to provide services as a safety net hospital, and we take that very seriously. If you think about some of the other larger cities in the country, it is not always that you have that specialty care, the transplants, et cetera, and the safety net sort of trauma hospital in the same place. You know, you think about Atlanta, they have Emory, they have Grady. You go to Houston or Dallas, and there are hundreds of hospitals. So it is not always common to have one entity serve all those roles, but that is our role in the state of Mississippi, and we take it very seriously, and we're very proud of it. Just a few numbers for you to see. These are admissions and ER visit numbers, surgery numbers. One of the things that I want to point out is this is a very medical kind of technical term, case mix index. Our case mix index is 2.17. That is something that is measured across hospitals in a uniform way that tells you basically how sick your patients are. The hospital in Mississippi that has the next highest case mix index is 1.8. It is a way to sort of back up what we say when we tell people we take care of the sickest patients in Mississippi. Just to give you an example, if a 20-year-old athlete playing basketball breaks his ankle, he has an ankle fracture that needs to be repaired. If his grandmother, who's 80 years old, falls and breaks her ankle, she has an ankle fracture that needs to be repaired. But those two patients are very different. You've got somebody that's young and otherwise healthy, no other medical problems, and their recovery is expected to be one thing. Whereas the grandmother may be on blood thinners, have high blood pressure, diabetes, lots of other things that would make her stay more complicated. So case mix index helps to figure out all of that. But our patients are very sick. About a third, whether you look at the hospital admissions, clinic visits, surgeries, pretty much all of our numbers, generally speaking, about a third of our patients are pediatrics, 2/3 adults. Going back to that SOS call we mentioned and the transfer of patients, We have, on average, 30 to 40 patients transferred to us a day from hospitals all around the state. And they are not all small, tiny hospitals. We take patients from some of the hospitals that are very busy and very good and big and see a lot of patients. But we have 30 to 40 patients that are transferred to us a day. And one of the things that I particularly want you to realize is we take care of patients from all over the state. I've got a couple of maps to show you, but we take care of patients from all across the state of Mississippi, every single county. So when you think about uncompensated care, that is something that, particularly in these last couple of years as hospitals have been under more and more stress, that has been something that has been talked about more. So every hospital bears some cost of uncompensated care, and that is care that's provided for individuals that don't have any insurance or they are underinsured. Their insurance does not cover actually the cost of their care. At the medical center, our range of uncompensated care per year is somewhere in the $130 to $180 million a year. And that's a lot of money. Like pretty much all of the hospitals, we receive supplemental payments, federal supplemental payments, DISH, MHAP. You've heard us talk about some of these things. That offsets, those programs are built to offset uncompensated care, and it does offset the majority. So it varies from year to year. Over the last 5 years or so, our uncompensated care costs that were uncovered by these federal programs range from in a given year from about 10 to up to $60 million a year. So we are constantly looking at ways that we can be financially sustained financially, and basically know we're going to start the year off in a little bit of a hole. Things that are not captured in uncompensated care cost, these are all federal definitions, but things that are not captured there are things like bad debt, high deductible plans where somebody might have a good insurance plan or have a high deductible plan, but they can't cover their portion of the cost. We have more uncompensated care costs than any other health system in the state. The things that fall in that category, the most common uncompensated care categories, are what you might expect. Unexpected things, trauma, fractures, blunt trauma, penetrating injury, stroke, all of those things that happen to a person that is typically unexpected. This map is a demonstration of our presence across the state. So I'm going to start right here close to me, telehealth. You heard earlier, I was glad to hear somebody else say it because I say it a lot. We have one of the best telehealth programs in the country. And you can see that across the state, we have multiple connections in telehealth. Our learners actually blanket the state. We send students out all over the state of Mississippi to receive part of their training and part of their education. And then this is the map that shows our own hospitals. We have 6, 4 are on the Jackson campus, one in Grenada and one in Lexington, and then where we have clinics across the state. In another few months, I'm happy to say that we'll actually have a little yellow dot in Greenville. We're working with them to help cover their neonatal ICU, and in Amory as well, same thing, the neonatal ICU. So our approach has been to be responsive to entities that come to us and say, can you help us with something? So particularly these clinic dots, in every community it's something different. It just depends on what the community asks us to look at. Very often it's pediatrics, but it's not always pediatrics. You heard Mr. Coward actually talk about neurologists and how hard it is to find neurologists. In Macomb, we're working with them to provide some neurology coverage and backup. But in Meridian, it's cardiothoracic surgery and pediatrics. You know, it's something different everywhere. But we are working to, through this model, extend our reach and our support, whether it's through technology and telehealth or some other kind of way of clinic presence across the state where we're asked to help and assist. We know that, and we say very often, we cannot take all the patients in Jackson. We do not want to take all the patients in Jackson. We can't take care of the patients in Jackson. Probably every one of you in this room has gotten a call from a constituent who has said, hey, my cousin's in the ER and we can't get them out of the ER at the medical center, and can you call somebody over there? And at any given moment, 3 times a day, we get an email update on our capacity status, and the one that came out at noon today, we've got 29 admitted patients that we're holding in the ER, and that's just a regular routine thing. So we want to take the patients in Jackson that need to come to us, that need a transplant. We can't do that somewhere else, but we also want to support the communities in other places so that all the patients don't have to come here, that there is the ability to do that. While I've got this map up, just to mention, because we talked, so there were so many comments earlier about OB and the care for OB, particularly in the desert. One of the ways that we have worked hard this last year and a half to extend our reach is a STORK program, S-T-O-R-K, where some of our team of obstetricians and others, OB doctors and others, are going out and working with nurses, paramedics, primary care physicians, physicians in the ER, all across the state, particularly in the Delta, to provide them some hands-on training on how to handle some of the OB emergencies, trying to bridge that gap to buy some time if somebody's in a tough situation until they can get a patient transferred. So, how are we working to increase access? These are some of the things that we are doing, and they should all be familiar to you. In almost all of these, you all have supported us in some way. So, looking at increasing healthcare workforce, focusing on recruiting and retention. For many years, you have supported the Rural Physicians and Dentists Scholarship Program. That is very positive, and we are seeing graduates come out the end of that. That's making a difference. You have helped us grow our School of Medicine, our School of Nursing, our School of Dentistry. These are all things that are important and impactful. Medical education is a long pipeline. You know, efforts that you make today, you're not going to see a result tomorrow or the next day, and maybe not next year, but a few years down the road is when you really see all these things paying off. Expanding access points across the state, just like I spoke earlier about telehealth. We are getting teleemergency and a number of other programs rolled out. Our pediatric and adult specialty and subspecialty clinics, building out the burn center, looking at ambulatory access, increasing our inpatient beds. As we speak, we are building out a couple of shelled floors at the medical center to increase our beds. We have more beds open today than we've ever had, and we still have that backlog, like I mentioned, in the emergency department of people waiting on beds and needing beds. We are building out an adolescent psych inpatient unit. We currently do not have one of those. It's very important. And then affiliating with other hospitals around the state, as I mentioned. This is just a graphic of the location of some of our pediatric affiliations and clinics. You can see, as I mentioned, it is statewide. And then this is on the adult side. For pediatrics, we've got 22 clinics, I think it is, 20 some odd clinics, and 40 something on the adult side, where we are trying to increase the access for patients. So one of the things I want to take a couple of minutes and talk about is cancer. When you think about outcomes for Mississippi patients, we are last in the country as far as cancer outcomes go. And that is something that has touched my family. It's probably touched everybody's family in here in one way or another. And the the kind of compelling thing is it doesn't have to be that way. We've got a lot of challenges in Mississippi, but this is one of those challenges that I think it is just an ethical imperative that we try to tackle. You can see, just as we kind of heard from the last presentation, a lot of those cancer outcomes are worse in the Delta than anywhere else. It is not because we have bad doctors or anything else. Just like with any other really big problem, there are 100 different reasons. In some cases, we don't have enough healthcare providers. In some cases, patients don't have transportation to be checked out, to have a primary care doctor. In other cases, people just wait too long before they are presented. In some cases, when they need a higher level of care, they cannot get to that next place. So there are many reasons, but this is a problem that we must tackle. One of the major pieces of this is something that's called NCI designation. That stands for National Cancer Institute designation. So when you think about those places that patients with cancer go, when they feel like I've got to go to that really premier place, I need to go over to MD Anderson, I need to go to Mayo Clinic, I need to go to Vanderbilt, I need to go to UAB to really get the best cancer care. That's what I need to do. What is it about them that makes them different? They are an NCI designated cancer center. Mississippi does not have one, Arkansas doesn't have one, Louisiana does not have one. There are 72 across the country, but we don't have any in this part of the country. Studies have shown that the survival rate for patients is improved in those NCI designated centers. It is a federal designation. It really focuses on what your research capability is. And when you achieve that, it designates that you have a certain amount of strength in clinical services, in research services, and therefore you have access to funding opportunities that you don't if you're not in that club. So being in that NCI designated club is the critical thing for us to really change what cancer outcomes look like in Mississippi. We are on that path. We've done a lot of work the last 5 years at the medical center, particularly in the space of pediatrics, children's care, transplant, and our focus for probably the next decade is going to really be around cancer because, again, this is a long path. We're hoping and planning in 28 or 29 to be ready to submit an application for this. We will need your help. We absolutely will need your help. Just focusing on a cancer clinical program will not move the needle. It's got to include this research piece. It's going to take investment in people, in facilities, in resources, in equipment. We are planning a philanthropic campaign. We are going to ask for support from you all from the state. We are looking for opportunities for federal dollars, and then our own investment in revenue bonds and clinical revenue. But this is a way that we can move the needle in Mississippi and make a big difference. This is a bit of our timeline that just shows you it is a 10-year plan. This is not an overnight sensation. Thinking broader about access, some of the things that we are supporting and that are important this session, we know there are a lot of policies that will be looked at, bills for you all to look at around access to care, to help get care to people sooner, presumptive eligibility, prior authorization, all of that is important. Supporting medical education and clinical workforce programs, just as you have done. Support for telehealth, and anything that eases that path for patients to have access to health care is positive. I want to end on just a couple of highlights for the medical center, have a chance to brag. So Leapfrog, you may not know, Leapfrog is a national organization that looks at publicly publicly reported data for hospitals as well as some survey data and gives hospitals a grade on their quality and their patient safety marks. It is not a perfect scoring tool. There is no perfect scoring tool related to patient care. It's not perfect, but it is something that happens across the country that people look at and people kind of understand what it means. Our Grenada Hospital in this most recent scoring, get a score twice a year, received an A, that's the highest grade, and at the medical center we got a B, and that's the highest grade that we have gotten since my time there. This chart goes back to 2015, that's when I started as the Vice Chancellor, and shows our journey from a terrible grade to now a grade that we are very much proud of. And you think about how does that compare to others? So the first organizations listed here are those organizations that are somewhat like us. They are academic medical centers, they are trauma centers, they are tertiary care centers, and you can see where we stack up with those in the southeast, and then 2 of the local Jackson hospitals. So we are awfully proud of that and want you to see that and be proud of that as well. And then my last comment, a little bit of this got cut off, but this demonstrates something that just happened at the hospital, at the medical center in December, in our transplant world. And there are actually patient names on here, and every time I see the patient names published, you know, the physician background in me about patient confidentiality almost has a heart attack, but I just feel like I have to tell y'all the patients agreed that it was okay for us to publish their names. But this is a drawing of something that we called a 7-way swap. So it is a kidney transplant, series of transplants that happened in 1 week, where we had 7 live donors and 7 patients receiving those kidney transplants, all in the course of a week. And it started with the live donor who said, hey, I want to give a kidney to you. Well, it turned out my kidney didn't work for you, but it worked for you. And so they were able, through all the blood typing and all the thing they do, to say, my goodness, I think we have the possibility for, this is transplant lingo, I didn't make this up, for a 7-way swap. So this is really phenomenal and rarely done within a transplant region, as best we can tell, never done before in a single institution. So we are really proud of that. And just to highlight transplants, this last year, 221 transplants at the medical center, which was a record for us. So I'm going to stop there. I know that was very fast, but I was trying to be mindful of the time.
Thank you, Dr. Woodward. Questions, Senator Parker?
Sure, I think
I can hear you. If that, yeah.
I can be loud enough for that microphone, but I appreciate your comments after the previous presentation. I wondered if this was going to be the best forum and time to do that, but I think things have worked out.
I wondered if I should have gone first.
But certainly appreciate your remarks. But listening to both presentations, a few questions came to mind. Because I look at UMMC's model across the state, and it certainly appears in my mind to be kind of a regional model, regional across the state instead of being just one region. And I think that in the previous presentation, there was some mention being made to that need for hospitals, providers, and other groups to work together. And I think there was even mention that UMMC would be part of that model, if some type of regional hospital authority were developed. So is it your opinion that UMMC, in a model like was proposed before, could be somewhat of an involved party or potentially a partner in something like that?
So let me say this. It's hard for me to really comment on that because I haven't seen anything in writing other than what was presented today. So a concept is one thing. What it looks like in a bill could be different. So I just have to put an asterisk by, I haven't seen anything in writing. But I will say whatever model the state comes up with to improve access to care, to improve, the right care for the right patient in the right place, we would want to be helpful to that model. Whatever that right role ended up being, I don't know.
Right, and as I look at some other things too that you put up there, I think, in a situation like that, you have other partners, looking at your analysis there, I think Baptist has been a strong partner, and I know last year I did some tours of both facilities. We're lucky in Jackson to have UMMC, and we're lucky to have Baptist. We're lucky to have Baptist up in DeSoto, where I'm from. But as we do look at solutions, particularly for the Delta, is it UMMC's position that you would be willing to, in some ways, and I don't partner in the right word, but share some of the responsibilities for that underserved areas with other partner hospitals who we might be able to convince to develop some interest in that?
We would want to be part of the solution. Now, the devil's in the details on what that looks like. Probably many of you in here know that for a number of months we were in negotiations and communications with Greenwood, back now, I guess almost a year and a half or 2 years ago. That fell apart. And part of that reason it fell apart was there was a model that would make sense for the Greenwood community and be able to be sustainable, financially sustainable. But it did not match with the expectations and the wishes of the community. So it does not, I don't think, help the medical center as we are trying to do the things like build a transplant program and do all those things, cancer that the state needs, to get ourselves in a position where it's a money-losing situation and we would lose money and it would be a financial drain. I feel like, absolutely do our share of uncompensated care, and we are glad to do that. But in taking on anything else that might be harmful like that, we have to be very careful. But we do want to be part of the solution.
So in that model you're kind of talking about, so say we took the example of, like OB type of care, the greatest need that's there, I could see just off the top of my head, a way where if a hospital were choosing to, kind of specialize in that more, your students as they graduate, you can have some type of program where you're feeding providers in there, who may not, particularly plan on practicing there for a career, but they might go there for a portion of their career, come back to UMMC or go to another part of the state. But just like we've done with the Rural Physician Scholarship Program, you can develop a method through UMMC and your other partner hospitals where you can maybe get that feeder supply in there that's repeatable and that is replaceable to help with that need.
And those are some of the kind of things that we can absolutely look at. And in a bit of a different flavor, but something similar to that, we have been doing in Grenada. So now that we have the Grenada Hospital, we have students and residents that are going there as part of their training. And what happens when that happens is students might see and experience a part of the state or a medical community that they never would have really thought about if they hadn't had that experience. So I think that's one of the things that certainly would be in the mix, those sorts of activities that we would be willing to look at and to figure out how can we help.
And I think that this will be my last question. It's in the same series of when we went to the NCI, type of model. My experience with that, and my colleague next to me, I think we have some shared interest on that. But you do have, NCI accreditation within Memphis, and there are some, kind of shared commitments that I think can be made through some partnerships that I know and some interests that I know is not legislative partnerships, but just other concerns of that community, where I think that in the appropriate maybe hospital setting or outpatient setting, you could maybe through UMMC, maybe some of our Memphis partners that are
Have some connections, yeah.
Have something that is established there, because I really and truly feel that if someone in DeSoto County is told that they have a 12% survival rate from their cancer, they have a better chance to strongly
That's right.
feel that someone from the Delta who's told, at a hospital in Jackson or Memphis, wherever, or oncology clinic, that they have a 10%, 12% chance, what I have found is that they go home. And so the red part of your statistic there is not going to change unless we realize that we do have to put those services closer to where that need is, and it's not a fault of their own. They're not, they just are unable to make those continued trips.
It's hard.
Make that investment.
It's hard.
No matter
It
what
is
car
hard.
they have, no matter what service they provide, we have to do a better job as a state putting that service closer to them. So, but I appreciate your comments.
Thank you.
They do serve a better purpose today in the grand scheme of how we're thinking about things, and I think you and UMC can be a great partner. In this.
Thank you. Thank you. Thank you.
Ms. Scott, don't let us down.
Well, I don't want to, because, knowledge is power. I want to ask you for capacity for general practitioners. What is your capacity to train general practitioners over at the medical center now?
So in that general practitioner bucket, we have a couple of different specialties. I'm not sure exactly what you're talking about, but family medicine, general pediatricians, internal medicine. So we have a family medicine residency program. We've had it for a number of years, and they match, I think it's 10 students a year. So they are training family medicine physicians every year. We've got general internal medicine and pediatrics as well, and those are all large training programs.
Okay, so the reason I ask you that
Okay.
is because if we look at the Mississippi Delta, and not just there, I looked at Jasper County, the counties that I recognized where there were no doctors. So my question to you is, would the University Medical Center be interested in increasing their capacity to train family medicine doctors?
Would we be interested in that? That's your question? Yes, we would.
And if you were interested in that and you were to develop a 10-year plan to maybe get us to, let's just say, if we targeted the Mississippi Delta for those doctors, and they said, he had a chart up there for about what they needed, to get to 50%, have you all thought about what it would take for monies from us to do that, because that would help to solve a problem?
So I'm going to comment on your question without really answering your exact question, but just to add a little to that. Sometimes it's not just about the number of people that you're training as much as it is about what can you do to attract them to the areas where there are not a lot of healthcare providers.
And so that's why we go back, why I tried to ask the gentleman the question about the Grow Your Own. Project Atlas just gave us the template. They said, invest in your local people. Grow your engineers, grow your data processors, grow your, invest in your local schools. So again, I go back to, if we were to adopt a policy of grow your own in Bolivar, in, the 13 counties that they identified, and let's just say we put some kind of STEM something over there at Mississippi Valley State University, where these children could matriculate there, as opposed to trying to get over to Columbus. And then you could go from there to feed people into your medical school. Is it a way that you all could create a plan, just a proposal, around something like that for us to look at, that would address trying to get doctors, let's just say, a 10-year proposal?
So I would need a little more specifics kind of what you're talking about, but
I'm trying to get doctors. I'm trying to get trained.
But the flip side of that is it is hard to recruit a single physician to a community where there's no healthcare infrastructure, or very limited healthcare infrastructure. So if you're a general surgeon and you're ready to look at jobs, You might look at a job in Tupelo or Jackson or the coast where you would join a group and you would know that your call would be shared and you would be in a group where you have colleagues. That's one experience as opposed to going to Indianola or wherever it may be in the Delta or Carroll County or Winona, where you're the only general surgeon in a 45-mile radius and you have no backup and no help. So it's not just about the numbers as far as recruiting and attracting somebody to a community as it is having some infrastructure there that is an attractive environment.
But it is about the numbers for a family doctor. I'm not talking about a specialist.
Mm-hmm.
I'm talking about a growing family doctors that grew up in Greenwood, that as an 8th grader, that have a little science interest. And then we develop them and we grow their path there. And then we provide you with people who could eventually go to medical school after they go to college.
Increasing the pipeline, I think, is very positive.
If we were able to do that, could you all come up with a 10-year plan to show us how we could, if we were recruiting college, people who had completed college and wanted to be a family medical doctor from the Delta, could you all come up with a plan that we could look at that would help us to address that?
I think
Is there any way you got somebody over there that could do that?
I think we could take a stab at it. I'm not, I think we could, yeah.
I would like to ask them if they would. I'm going to introduce a little old bill, something like that. But I would like to ask them, see if they would. I think this grow your own thing is the way to go for us. Nobody wants to.
Right, and Dr. Parker has some experience with that or knows a program similar. We can talk to him after this. So any other, gentleman from Lee.
Yes, I have just a quick question, just to piggyback on what Scott. In the next 10 years, since we have a nursing crisis, what are you doing to increase, make sure that we can graduate nurses to work along with the doctors and side doctors and stuff like that? We improve that.
So we have grown the class size of our nursing school. You all appropriated some funds for us to be able to expand our nursing school building, and that will allow us to grow even more. We have within our own health system established scholarships for students so that if they will commit to working for us, they can attend, that's a tuition scholarship. So we are trying to be additive to the efforts that you all have made and the investments that you have made to help with the nursing workforce. But we are growing our nursing workforce. We are growing our nursing programs. We've just in the last year added new programs to the nursing school in Oxford as well. So we are growing it as fast as we can grow it. It is a really big need in the state.
How many students have you have? What's your goal, the maximum student that you're trying to get for each semester to fulfill your goal?
So the total number of students in our current School of Nursing body is in the 800s, 800 and something. And there are different programs that are different durations. So I can't quote you the numbers that we graduate each semester, but I will tell you with that 26% growth, that would put us up to around 1,000 students enrolled. We've got one-year programs, we've got two-year programs, we've got doctoral programs and master programs, but the focus that we've really had these last few years has been on the 1- and the 2-year programs, accelerated programs, and the traditional programs for the students that graduate with the BSN, sort of what we think of as the bedside nurse. Thank you. From the BSN program, I'll have to get back with you on that. Unless somebody here knows that number, I don't know. I've got some brains here with me that might.
I'm pretty sure it's about 350. We generally retain about 70% of the nursing workforce in Mississippi. And those are not just our statistics, that's across all of the community colleges and other, that's an IHL number.
All right. I want to thank Senator Bryan and the Senate for letting us facilitate this hearing.
Thank you.
Dr. Woodward,
Thank you for
thank
having
you.
us.
On behalf of the legislature and the people of Mississippi, we appreciate your leadership, and this was a great presentation.
That was a whirlwind, fast presentation, but thank you for your
All right, Senator Bryan.
I first of all want to make everyone aware that there is a microphone stand right in front of me, and on it says, "Do not remove from stand." You'll notice that the chairman and I have already ignored instructions. So, the Public Health and Welfare Committee, to say the least, has a very broad area of jurisdiction, and we've been focusing on public health, and that's pretty broad. The purpose of this series of hearings is so that members of the committee and other interested folks can just have an opportunity to sit without any particular agenda, look at what's going on in the state, look at some of the issues, and scratch our heads and think. And I think this is the people that presented today were invited to come up here before the committee and help us in that ongoing effort. Now, tomorrow, we're going to meet upstairs. Other than that, it's same bat time and same bat station.
Rise and report. You got tomorrow, right?